Dr. Mellon. Today we're still talking about drugs, we're still talking about depression. Last time we were talking about SSRIs. Today we are going to talk about SNRIs. So if I look it up and I show it on the screen so you can read it, serotonin, norepinephrine, reuptake inhibitor. So if serotonin is fantastic for depression, then surely if we max out your serotonin, add a little bit of norepinephrine, it'll be better or different. So let's get to it. So MDD, SNRIs. There's effectively, when it comes to depression specifically, there's 4 of them. Let's go to the parent group so I can just show you pictures and stuff, and we'll go through that. FDA approval. There we go. So there's 5 SNRIs, but there's only 4 that got FDA approval when it comes to MDD, that top row. So basically everybody but milnacipran. It failed it struggled, tried to get fibromyalgia. Nobody prescribes it for that because it didn't work. But somehow when you took half the drug away, it magically passed the sniff test. Venlafaxine's an old drug, so it's approved for everything. Diloxatine, it looks like a lot, but it picked up pain, and all those bottom things just mean pain. For some reason, venlafaxine, awesome for anxiety. You take out half the drug, and now not awesome for anxiety. But that's kind of those pieces. Half-life, these are weird. This is nothing like SSRIs. I read a big pharmacy paper. There's like 30 pages on all these things that was written in the last couple of years. I read it a couple days ago. So these are clean drugs compared to the SSRIs. They affect serotonin, norepinephrine, and they don't tend to interact with a lot, and they don't last all day. So venlafaxine, the first one that came out, I'm sure it wasn't called IR, an immediate release initially. It was a terrible drug, and then they flipped it over because of the side effects, trying to dose it twice a day. It didn't work. But they all last 10 to 15 hours. And the story I told last time, it's the story that we're told, is like paroxetine, 21 hours. That's not even a whole day. People have horrible withdrawal effects. People do fine with these for a day before the withdrawal effects kick in, and they only last half as long. It's kind of weird. There's some trickery to this, but it's not as simple as the stories everybody says. Only thing I want to say, kind of the pharmacokinetics things, stuff to think about. So the drugs are on the left. Let's talk about the metabolism first. So venlafaxine and duloxetine, these drugs are nothing alike. I mean, difference between aspirin and ibuprofen, we call them NSAIDs, nothing alike. Venlafaxine and duloxetine both go through the 2D6 cytochrome P450 system. So they can interact with drugs, those two, if they go through that route. Venlafaxine does because it becomes desvenlafaxine. That's the metabolite. Basically, other than that one change, they don't do anything. They stay in the blood. They get basically, I think it's like they get gluconated, is that the right word? Through the liver, so it gets charged molecules so you can pee it out, and most of it gets peed out as that compound. It doesn't break apart into a bunch of fluffy molecules. Now, the other thing that I want to point out on this, or to think about, is we're told about these ideas of serotonin to norepinephrine ratio. It's like, look at that, 30 to 1. The other one's like 10 to 1, 10 to 1, 1 to 1, 1 to 2. That story is not correct. Technically, yes, but no. So, see that 30 to 1 for venlafaxine, and then duloxetine says 10 to 1. That's how strongly they bind to these things, but they're considered sequential. They will saturate SSRI first. Basically 100%, any meaningful thing. So they will just flood and bind as SSRIs. That's all they are, I guess, at low doses. And when you start pushing it higher, eventually it's saturated them and it looks for something else to bind, just like lots of other drugs. And so it'll go from being an SSRI, they saturate, then they become a norepinephrine reuptake inhibitor. Then if you just keep being a jerk and saturating them, you'll get dopamine out of it eventually. But these stories of, it's more serotonin, more epinephrine, it's more of like you're just not giving as high a dose of one versus the other, and they're not equivalent 1 to 1. But they're sequentially binding, so it's just flooding SSRI and then going norepinephrine. So hopefully that made sense. So let's kind of talk about them in order, kind of the piece. So venlafaxine was the original, so let's talk about it. All right. So venlafaxine, 1993, came out. Lasted like 5 hours. You got all the bad side effects. They double dosed it to get BID, cut the dose in half. And then they're like, okay, whatever, extended release, let's quit this. And every other one is extended or sustained release, because the immediate releases are bad. So what do we want to know about this? So it works we're focusing on depression. Some people it says it has no ceiling effect because you can keep increasing the dose. I don't quite understand that because it's basically you're just increasing norepinephrine over and over after that. So I guess if you slam an EpiPen into your leg and that makes you feel better, then yeah, no ceiling effect. And it does go through the 2D6, so that matters because remember, venlafaxine turns into desvenlafaxine. So side effects, it's the same for all of these guys and girls. These, I guess, these pills with sexes attached to them. They should, as far as I can tell, have the serotonin kind of side effect profile because milnacipran, some of them, they're like, oh, sexual dysfunction. They should all have that because they are SSRIs when they're lower dose. But what we really care about and everybody talks about is, hey, if you give a person lots of norepinephrine, what happens? This happens. Headache, tachycardia, restless, nervous, dizzy, insomnia, sweating, anxious. Just, I don't know, pretend somebody's about to murder you all of a sudden, and how does it make you feel? And sustain that for a while. There you go. Norepinephrine, EpiPen. And they've kind of proven this before because when they did it with venlafaxine and tested, when they gave the immediate release less than 100 milligrams, which is not very effective, I guess, I don't know, it didn't have a lot of norepinephrine effects. So like, good, only 3 out of 100, or, that's pretty good. When you give it triple that dose, it's 10% at that point. It's every 10th person's like their blood pressure's going up and they're not feeling so hot. That should be a linear dose. I mean, you should, if I gave them 1,000, it should just be more. And just the fact that there's different drugs and names, it just means they're less potent, I guess, but they're all doing the same thing. Now, this is huge to me because I didn't really appreciate this till outpatient. So again, it's a discontinuation syndrome is what you should call when medications stop in psychiatry and you end up with withdrawal effects. So you feel bad with venlafaxine. It's hard to get off. I mean, we're talking benzo hard. Some people, it's a couple months, maybe more, before you can get them off like venlafaxine because they feel horrible. Nausea, upset stomach, pain, diarrhea. They can't sleep. Dizzy. They just feel like crud. Rebound tachycardia, right? It's doing the opposite. You've been smashing those receptors and now they're not being pushed anymore. And then, of course, from venlafaxine, you have its pretty cousin, desvenlafaxine, Pristiq. So it was approved for depression in 2008 in the United States of America, and then Europe promptly said, it doesn't work any better. Why would I make a Me Too drug just so they can make a bunch of money and it doesn't work any better? I think it's supposed to be a little bit smoother, but people have been drug repped a lot right now, and I don't really trust a lot of other doctors whether that's actually the truth and like the side effect going, oh, it doesn't cause as much of these. Maybe you're better at selling the placebo effect when it's a new drug. It should be the go-to for everybody who's, I guess, a non-psychiatrist because of this fact. MDD, 50 milligrams a day. It didn't work. Go see a psychiatrist, right? It's just one dosing. It's so dumb. If it works, and that's true, that everybody should just get it. Like, I don't know. I mean, it's so easy. You should be able to get over the counter at that point. Why do you need us? So, yeah, it's a Me Too drug. I don't really care about Pristiq. If you like it, go for it. Diloxatine. Okay, so this, again, nothing like venlafaxine. Came out in 2004. Happens to be an SNRI. Difference between aspirin and being ibuprofen. That's what I said earlier. So what do we want to know about this or say? So they got the FDA approval. They fished around. Did I click on it? Oh, no, I did. Sorry. Is pain and depression. You have pain and depression. You can be genius status psychiatrist by acting like a pain doctor because they're trying to be genius in their own special field. You have depression, you have pain. Here's the one drug that got that FDA approval. Yeah, why not? Shoot. some people it helps. It got FDA approved for it. It helps enough people, right? So go for it. Its withdrawal effects, it's a very different drug. Its withdrawal effects tend to be a little not as bad as venlafaxine. If I had to pick out of these two to just hand somebody, I'd probably go Diloxatine every time, because venlafaxine's withdrawal effects are awful. This one's pretty bad too, but it's not as frequent. And now we go to the new fancy drugs. Where is it? SNRI, milnacipran, levomilnacipran. So you might not have heard of these guys yet, but maybe you have. So they're new, 2009, 2013, and maybe everybody will get to prescribe them in a few years, because theoretically the patent will end. Again, just notice the half-lives. They're short, and they still work. So that's kind of cool. It's very different than the story we're told with SSRIs. SSRIs are very fluffy, weird molecules, other than, I guess, citalopram, escitalopram. So milnacipran, it was a racemic mixture, and so they cleverly came out with another drug after the first one when they took the more active one out. I guess they probably tested both. So the mixture did not pass the MDD test, so sugar was just as good. So I would bet dollars to donuts they tried both the levo and the dextro version. One of them beat placebo, and they went, that's the one. That's the one that works for depression. Yeah. The other one totally didn't. That one does. Maybe it's true. I have no idea. They just come out of the kidneys. It doesn't really interact with stuff. They're chasing stuff, Alzheimer's, things you can see. What's cool about this drug? You pee it out. They're all extended release, like I said, SR, because it has to be. I don't know. I think it's probably a Me Too drug. I don't know what to tell you about it. Side effects, anything fancy? I think they probably all really have this side effect. It just depends on how it went through it's sexual dysfunctions. They're serotonin, SSRIs, right? They all cause norepinephrine issues as they go up. This one is interesting because it had the 1-to-1 and 1-to-2 ratio. So levomilnacipran, it actually has a lot of norepinephrine affected, but somehow doesn't cause massive norepinephrine problems. So I don't know. It's not a sequential blocker like the other ones were. So time will tell if this drug is a Me Too drug or some new actual useful drug. We don't know yet. We will find out. All right. This has been Mostly True Psychiatry with Dr. Mellon. Thanks for tuning in.